So I want you to take a second and just think about a specific medical condition. When you hear the words cerebral palsy or, CP, what immediately comes to your mind as the root cause?
Right. It's usually one specific thing.
Exactly. If you're like almost everyone out there, and honestly, I'm including medical students and seasoned nurses in this, you probably have this reflexive association. You picture a delivery room emergency.
Yeah, you picture a lack of oxygen during birth.
Right. Birth asphyxia. It feels like that is the established, unquestionable narrative.
It is a deeply ingrained assumption, and I mean, it's easy to see why it took hold.
Right.
When people think of birth injuries, they picture these acute, terrifying moments during delivery.
Really dramatic events.
Exactly. Things like a placental abruption, where the placenta, which is, the baby's entire life support system, suddenly peels away from the uterine wall before the baby is actually born. Yeah. Or a uterine rupture, an actual tear in the uterus itself. These events cause sudden catastrophic oxygen deprivation. And because they're so dramatic and they leave a lasting emotional scar on everyone in the room, they just kind of became the default explanation in the public consciousness for what causes CP.
But in this deep dive, our mission is to completely dismantle that outdated myth. We have a stack of medical notes today that essentially rewrites our entire understanding of cerebral palsy.
It really does. It flips the whole script.
It totally does. We're going to explore the true timeline of how these brain injuries actually happen. We'll look at the real risk factors that drive the numbers. And we're going to end up exploring a cutting-edge genetic frontier that is literally changing diagnoses as we speak.
Okay, let's unpack this.
Let's do it.
If the data says birth asphyxia isn't the main culprit, I mean, what are the actual numbers?
Well, when you look at large-scale, modern epidemiological data, the reality is starkly different from the myth. Birth asphyxia accounts for a surprisingly small slice of CP cases.
How small are we talking? The estimates vary a little bit depending on which source text you're looking at. One of our sources puts it at under 12%, while another pins it at under 10%.
Wait, 10 to 12%. That means roughly 90% of all cases have absolutely nothing to do with a lack of oxygen at birth.
Correct.
That completely shifts how we have to look at this.
It forces a total reset. And, if you're studying this or just trying to be a well-informed advocate, the goal isn't to memorize whether the exact number is 9% or 11%.
Right. It's the bigger picture.
Exactly. The crucial takeaway is that asphyxia is a minority cause. Full stop. If you ever come across a premise, whether in an exam question, a legal drama on TV, or a news article that implies asphyxia explains the majority of CP cases, you can immediately flag that information as severely outdated.
Okay, so we have to clear the board entirely. So with the asphyxia myth out of the way, we obviously need a new framework. If CP isn't just, something went wrong during delivery, how should you actually visualize the development of this condition?
The most accurate way to understand it is through a strict timeline. A brain injury that results in CP doesn't just happen in that single chaotic moment of birth.
Right.
It can happen prenatally, meaning during the pregnancy, or perinatally, meaning around the immediate time of birth, or postnatally, meaning well after the baby is born.
Okay, let's focus on that postnatal window for a second, because it extends much further than I think most people realize.
Yeah.
We're talking about roughly the first 2 years of life.
Up to about 2 years of age, yes.
Which is wild to think about.
It is. But the reason for that specific extended window is that human brain development doesn't just stop when you cut the umbilical cord. For those first 2 years, the brain is still incredibly active.
It's still building itself.
Precisely.
Yeah.
It is still physically forming, migrating cells, and organizing its vital networks.
I like to think of the developing infant brain in those first 2 years as being like wet cement.
Oh, that's a good way to put it.
Right. Because if you drop a heavy wrench on a dry, cured sidewalk, nothing happens. It just bounces off. The structure is set.
Right. The damage is minimal.
Exactly. But if you drop that same wrench on wet cement, whether that wrench is an infection, a physical trauma, or loss of blood flow, it leaves a deep, permanent impression that sets into the very foundation of the sidewalk.
That perfectly explains why an infant's brain remains so vulnerable to permanent motor deficits long after they leave the hospital. That wet cement period is highly sensitive to any disruption.
So using this timeline, how does the medical field break it down?
They divide CP into two massive top-level categories based on when that disruption happens. You have congenital CP and acquired CP.
Okay.
Congenital refers to an injury or a maldevelopment that occurs before or during birth. And this category is massive, accounting for roughly 85 to 90% of all cases.
Leaving only 10 to 15% for the acquired category. That's an injury happening after about 1 month of age, taking place on that wet cement up to age 2. But even though acquired CP is the smaller slice, our sources note that it's actually much easier for doctors to pin down clinically.
What's fascinating here is that acquired CP is usually much more straightforward to diagnose in terms of its root cause.
Why is that?
Because you're almost always dealing with a discrete, identifiable event. You have a healthy baby, an event occurs, and then you have developmental changes.
It's a clear before and after.
Exactly. And the leading cause of acquired CP is a perinatal stroke.
Wait, when we say stroke in an infant, are we talking about the same mechanisms we see in adults?
Mechanistically, yes. A stroke is a disruption of blood flow, and it comes in a few forms.
Okay, like what?
Well, it could be ischemic, which is essentially a blocked pipe, a lack of blood flow to a region of the brain causing tissue death. Or it could be hemorrhagic, which is a burst pipe, active bleeding into the brain tissue.
Right, the burst pipe.
Yeah. Or it could be thromboembolic, meaning a clot formed somewhere else in the body, traveled through the bloodstream, and lodged itself in the brain like debris clogging a drain.
Okay, so if strokes represent plumbing issues, what happens when the threat isn't a lack of blood, but an active biological attack on the brain tissue itself? Because that brings us to the second major cause of acquired CP.
Right, severe central nervous system infections during infancy. We're talking about conditions like meningitis, which is an infection of the protective membranes surrounding the brain and spinal cord.
Or encephalitis.
Exactly, encephalitis, which is an infection of the brain tissue itself. These infections unleash a massive inflammatory response.
And inflammation is bad news for wet cement.
It's terrible news. In an adult, that inflammation is dangerous, but in that infant brain, the swelling and immune response can permanently damage the developing motor pathways.
Wow. And the third major bucket for acquired CP is physical trauma, right?
Yes. This could be accidental, like a severe car crash, or non-accidental, such as abusive head trauma.
But the common thread across stroke, infection, and trauma is that you have a clear event documented on a medical chart.
Which is the exact opposite of what you find in the other category. For the 85 to 90% of the congenital cases, we have to step away from clear-cut, single events.
And wade into a very complex, often murky web of compounding risk factors.
Exactly.
So let's wade into that web. Because if congenital causes make up the vast majority of cerebral palsy, we need to know what's actually driving those numbers.
We do.
And according to the notes, the single strongest risk factor is prematurity, just being born early.
Prematurity is the heavy hitter, absolutely. And the data shows it is highly dose-dependent. The earlier the birth, the more dramatic the risk.
Yeah, the numbers on this are staggering. If you look at very preterm infants, these are babies born before 32 weeks of gestation. The incidence of CP is around 8 to 9%.
Which is a huge jump.
Right. But if you look at late preterm infants, those born between 34 and 37 weeks, the incidence drops to well under 1%.
It's incredible.
You're looking at roughly a 10-fold difference just based on a few extra weeks of development in the womb.
It really highlights just how critical those final weeks of gestation are. The fetal brain isn't just growing in size during the third trimester, it's fortifying itself.
Fortifying how?
Well, the blood vessels in the brain of a baby born at 28 weeks are incredibly fragile. They haven't developed the structural integrity they need yet.
Which explains why bleeding in the brain, specifically periventricular or intraventricular hemorrhage, is another major independent risk factor listed here.
Exactly. Those fragile vessels are extremely prone to rupturing, especially under the physiological stress of being born early and needing breathing support.
That makes a lot of sense.
When severe hemorrhages happen in those vital ventricles of the brain, the risk of CP skyrockets. And tracking right alongside this is a very low birth weight, specifically infants weighing under 1.5 kilograms.
Because low birth weight is essentially a physical marker of that same prematurity.
Bingo.
Okay, I have to pause here because here's where it gets really interesting. I was looking at the source notes regarding other risk factors, and I noticed multiple births listed.
Ugh. Yes, twins, triplets.
Right. And I need to push back on this, or at least ask for a mechanical explanation. Are you telling me just sharing a womb causes brain damage?
Well,
Because physically, that doesn't make any sense to me. Is there some magic trick to being a twin that injures the motor cortex?
That is a great catch, and I love the clinical reasoning there. No, sharing a womb does not directly damage the brain tissue. You're touching on a critical concept in medical data analysis here.
Okay, I'm listening.
Multiple births carry a higher risk of CP, strictly because twins and triplets are significantly more likely to be born early.
Oh, so it's a statistical illusion. It always leads back to prematurity.
Exactly. Prematurity is a mediating factor. This is a classic textbook example of a confounding variable.
That is such a vital lesson in critical thinking for interpreting data.
It really is. If you see a headline saying, twins have higher risk of cerebral palsy, you might assume the crowding in the uterus causes a physical injury.
Right, like they're just bumping into each other.
But the actual mechanism driving the risk is gestational age. It is not twins cause CP, it is twins are more likely to be born early, and the extreme fragility of a premature brain causes CP.
I love that. It forces you to look past the surface level association and demand the actual biological mechanism.
Always look for the mechanism.
So prematurity and fragile blood vessels are driving a massive portion of congenital CP, but they don't explain everything. To fully understand what happens in the womb, we have to look at environmental factors too, right? Specifically, infections.
Yes. Maternal and fetal infections play a very significant role in congenital cases, even in babies carried to term.
Which infections are we talking about?
The two most frequently implicated infections noted in our sources are chorioamnionitis and congenital cytomegalovirus, or CMV.
Okay, how does a maternal infection actually reach and damage the baby's brain?
Well, with chorioamnionitis, which is a bacterial infection of the fetal membranes and the amniotic fluid, it creates this massive inflammatory storm.
Like we were talking about earlier with the infant infections.
Exactly the same principle. The mother's immune system and the fetus's immune system start pumping out inflammatory cytokines to fight the bacteria.
And those cytokines cross over.
Yes. Those cytokines can cross into the fetal brain, and they are literally toxic to the developing white matter.
And what about CMV?
With CMV, the virus itself can cross the placenta, directly infect the fetal brain cells, and completely disrupt their growth and migration.
Wow. Understanding these specific mechanisms becomes really important when we look at specific physical manifestations of CP. Because cerebral palsy isn't just one single presentation, right? There are subtypes.
There are several subtypes, yes.
And the sources specifically highlight dyskinetic CP.
Dyskinetic CP is a very distinct subtype. Unlike spastic CP, where the muscles are constantly tight and stiff, dyskinetic CP is characterized by involuntary, uncontrolled movements.
Constant rising.
Right, and it has its own unique set of causes.
The sources list perinatal hypoxia ischemia in term infants, intracranial hemorrhage, stroke, and general brain maldevelopment as drivers for this subtype. But the most notable one that jumped out was kernicterus.
Yes. Kernicterus is a crucial mechanism to understand. It results from severe, untreated hyperbilirubinemia.
Okay, let's decode that for a second. Hyperbilirubinemia, basically way too much bilirubin in the baby's blood, which is what causes jaundice, right? The yellowing of the skin.
Exactly. And jaundice is incredibly common and usually harmless.
Right, you put them under a special light.
Exactly. Simple UV light therapy. But when bilirubin levels get dangerously high and aren't treated, it becomes a neurotoxin.
Oh, wow.
In a newborn, the blood-brain barrier isn't fully sealed yet, so that toxic bilirubin crosses into the brain tissue and specifically targets and destroys a region called the basal ganglia.
And the basal ganglia is essentially the brain's movement control room, right? It filters and smooths out our muscle commands.
Exactly. When the basal ganglia is damaged by bilirubin, the brain loses its ability to inhibit unwanted movements.
Oh, so it's not that it can't move, it's that it can't stop moving.
That's a great way to say it. That specific bilirubin-basal ganglia connection is what leads directly to the involuntary writhing movements we see in dyskinetic CP.
So what does this all mean for a patient in the real world? Why does categorizing all these specific causes like kernicterus actually matter? Why not just say they have motor delays, let's call it CP, and leave it at that?
Well, if we connect this to the bigger picture, categorizing these causes is the foundation of clinical pattern recognition.
Pattern recognition.
Yes. When you link a specific cause, like severe jaundice, to a specific damaged area, like the basal ganglia, it allows doctors to anticipate exactly what they should see on an MRI.
Oh, so it tells them where to look.
It guides targeted imaging, exactly. It also guides therapy because you understand the precise mechanism of the physical deficit. It moves the diagnosis from a vague descriptive label to a precise, actionable roadmap.
You aren't just treating a symptom, you're treating a known pathway. But just when we think we have this all neatly mapped out, we've got the timeline, we've busted the asphyxia myth, we understand the inflammatory storms and the prematurity stats, the source material throws us a massive modern curveball: genetics.
This is genuinely one of the most forward-looking, rapidly evolving frontiers in pediatric neurology right now.
Yeah, that wasn't always a thing, right?
For decades, genetics simply wasn't a major part of the CP conversation. The assumption was always environmental, an infection, a bleed, a lack of oxygen.
Right.
But as genetic testing, specifically whole exome sequencing, has become more accessible, a major shift is happening.
For context, for those listening, whole exome sequencing isn't just looking at the chromosomes under a microscope. It's reading the actual spelling of every single protein-coding gene in the body.
It is incredibly detailed.
And the sources say, we are finding that a meaningful chunk of cases historically lumped under the broad umbrella of cerebral palsy actually have underlying genetic drivers.
The data from recent studies is just eye-opening. One study found that roughly 10% of children who had a CP diagnosis actually had a clinically relevant pathogenic copy number variant.
Meaning entirely missing or duplicated chunks of DNA that were disrupting brain development.
Right, structural changes in the DNA.
And then a separate study in the notes, using that whole exome sequencing, found that about 14% of their cohort had a single gene disorder driving their condition. Just a single typo in their DNA causing the motor deficits.
Now, I have to issue a strong statistical warning here.
No.
If you are looking at these notes, it is very tempting to look at 10% with a copy number variant and 14% with a single gene disorder and just add them up to conclude that roughly a quarter of all CP cases are genetic.
I mean, I was literally just about to do that math. Why can't we mash them together?
It's a great lesson in scientific rigor. Those were two different studies analyzing two completely different cohorts of patients and applying two different diagnostic techniques.
So it's apples and oranges.
Exactly. You cannot cleanly stack those percentages. However, looking at the combined weight of the modern evidence, it is entirely safe to say that a very meaningful chunk, potentially up to a quarter of atypical cases, might have a discoverable genetic driver.
That's still a massive portion of the pie. And this leads us to what is easily the most high-stakes, dramatic part of this entire deep dive, the concept of CP mimics.
This is where the clinical stakes reach their absolute peak.
What exactly is a mimic in this context?
A CP mimic is a genetic condition that looks identical to cerebral palsy on the outside.
Okay.
The child has motor delays, muscle tone issues, maybe spasticity, but the underlying cause is entirely different. Specifically, some of these cases are inborn errors of metabolism.
Okay, let's visualize what an inborn error of metabolism actually is. Imagine the human body is a massive factory, and enzymes are the workers on the floor.
I like this.
If you have an inborn error, you're missing a very specific worker, maybe the waste disposal worker. The factory keeps running, but because that worker isn't there to break down certain chemicals, toxic metabolic garbage starts piling up on the factory floor.
Until the machines physically grind to a halt.
Right, and sustain damage.
That is a perfect analogy. The toxic buildup damages the brain, causing motor issues. But the kicker here is that these mimics often happen in patients with zero documented risk factors.
None of the stuff we talked about.
None of it. There was no prematurity, no maternal infection, no low birth weight, no birth asphyxia.
And I imagine their MRIs look different too.
Exactly. When you look at their brain MRI, it doesn't show the classic scars of a stroke or a hemorrhage.
Because they're driven entirely by a monogenic cause, a single genetic mutation. And why this is so critical, why this should absolutely blow your mind, is that some of these inborn errors of metabolism are highly treatable.
That is the crux of the issue. This raises such an important question about how we diagnose.
Treatable how?
If you catch an inborn error of metabolism early, sometimes the treatment is as simple as a highly specialized dietary change to stop the toxic buildup, or an enzyme replacement therapy.
Oh my God. Think about the monumental tragedy and hope wrapped up in that.
He's staggering.
Imagine a child who starts missing motor milestones. They have no risk factors, but they get filed under a permanent, static, cerebral palsy diagnosis. They might be put in a wheelchair for 15 years, undergoing physical therapy that isn't working, all because they are missing an enzyme.
Oh, because they got the wrong label.
They're carrying a lifelong label for a static brain injury they don't actually have. while completely missing out on a dietary change or treatment that could have preserved their motor function.
It completely changes how aggressively doctors must pursue investigations today. This entire conversation about etiology, the root cause of the disease, is not just academic trivia for a textbook.
No, it's life or death, basically, or quality of life.
Exactly. When a clinician sees an atypical presentation, a child with motor issues but no history of prematurity, no clear acquired event like meningitis, and normal-looking MRIs, they cannot just shrug and label it CP. They have an ethical and medical imperative to go looking for those genetic mimics using modern sequencing.
Because finding it could alter the entire trajectory of a human life.
Absolutely.
Let's do a quick recap of the journey we just went on, because we covered a tremendous amount of ground. We started by dismantling the birth asphyxia myth, showing that oxygen deprivation at birth accounts for less than 10 to 12% of cases, not the majority as public consciousness assumes.
And then we established a strict developmental timeline framework, revealing that 85 to 90% of cases are congenital.
Right, and within that congenital category, prematurity is by far the heaviest hitter, acting in a highly dose-dependent manner because of how fragile the developing brain's vascular system is.
We also looked at the acquired category, driven by clear events like strokes and infections in those first 2 years of life when the brain is, as you said, like wet cement.
We learned how to spot confounding variables, why twins have a higher risk, which is really just a disguise for prematurity. And finally, we explored how modern genetics is unmasking these incredibly high-stakes CP mimics.
It really serves as a masterclass in how established medical facts evolve over time.
They don't just stay static.
No. When we start asking the right questions, separating out the confounding variables in our data, and applying new technologies like whole exome sequencing, we transition from relying on assumptions to gaining a deeply actionable understanding of the human body.
And that is exactly why this deep dive matters to you. It's about recognizing that medical knowledge isn't static. The absolute facts of 20 years ago are being rewritten today by people willing to look closer at the data.
It's an ongoing process.
Which leaves me with one final provocative thought for you to mull over as you go about your day. We just learned that a meaningful chunk of modern cases might have a discoverable genetic driver, and that some of these are actually treatable metabolic mimics. So think about this. How many adults are out there right now in their 30s, 40s, or 50s, living today with a childhood diagnosis of cerebral palsy, who might actually have a completely different, potentially treatable genetic condition that was simply invisible to the medical technology of their childhood?
It is a profound, paradigm-shifting question to consider.